Good morning. Have we started letting people in, Elizabeth?
Yes.
Okay. Good morning, everybody. Welcome to our health hour. My name's Ngozi Ediosage. I'm a paediatrician who works in Manchester, and I'm also the chair of the Caribbean and Africa, not the chair, that's Charles's job. I'm the medical lead for the Caribbean African Health Network. I think I'm a bit discombobulated this morning because our speaker that we've scheduled for the day is not yet here. So it does mean that we've been a bit flustered. But I am someone who likes to keep to time, and because we got to 11 o'clock, I decided that we should start really, even though our speaker's not here. And that's because there are always issues that I know that those of you who log on a regular basis want to speak about. We've been holding this now for 18 months, and one of the things I've realized is that irrespective of what topic we're addressing, that COVID is still here 18 months later. We thought this was going to be something that was a flash in the pan and be here, and then once we all got vaccinated, it'd be gone, but it's still here with us. So I'm sure that you have questions about that. You may also have questions about the vaccine strategy that is now being rolled out, which is different to what we're told at the beginning. If you are working in a care home, that's already changed for you. If you work in the health service, that will change for you from next year. And I think there is, I've heard some murmurings that it might change for everybody, depending on whether you want to travel out of the country or you want to access recreational services. I've just been told that he's here now. So apart from what we're going to talk about today, if you have questions about the vaccine that you still have, you pop them in the chat, and as health professionals, we'll do our best to answer that as well, because I understand and appreciate your concerns. But today we do have, our speaker is a doctor who will be known to you if you've logged on to us before, and his name is Dr. Mohammed Kamara, and he wants to talk to us about diseases of the heart, really, specifically when your heart stops, which can be quite scary for the person who's involved, and I think sometimes just as scary for people who are around us. And we've had stories of people who were with somebody who collapsed from a heart attack or cardiac arrest. And even if you were not medical, there are things that you might be able to do to intervene and help. So Dr. Kamara is going to talk to us today about some of those things that you might want to do. So thank you for coming, and I'll hand over to you now.
Thank you, everybody. Good morning, everyone. Thank you for having me. Let's see, all right, okay. Screen sharing, please. Okay, see what happens. Right, can everybody see that? Hello?
Yes,
it says
sharing your screen, Dr. Kamara.
Can everybody see that?
Yes.
Right. The internet can be problematic sometimes, and hopefully this would work all right. Anyway, I think we talked about this before, and a few times I've actually had to deliver this talk on a very important topic, one which literally means that time is of the essence. Literally, it means just a minute of lost time in commencing CPR, as is cardiopulmonary resuscitation, would actually result in 10% chances lost in trying to revive the person who is dead, literally. So it's important to understand that, you know, CPR, for it to be effective, it has to be started as quickly as possible. And you would find out as we go along, if the internet allows me to do what I want to do. Anyway, because of the importance of this topic, cardiac arrest is actually been given a month, you know, it's just gone past actually. October is the sudden cardiac arrest month. Now, I usually start with icebreakers. Now, I don't know whether anybody knows what to do when you find somebody collapsed, because the collapses or the arrests do happen mostly at home, and they're witnessed mainly by relatives, you know. So when you see somebody collapsed, the first thing to do, people might think, is that, you know, go and find out whether this person is breathing or whether they're alive or not. Yeah, it's a good thing to do, but remember, if you're not protecting yourself, making sure that you are safe yourself, you would end up probably causing yourself more harm than good, because you might think you're doing something good by going to try and save this person, but then exposing yourself to danger. So the first thing to do is to approach safely. Make sure that you're safe, because if there's a cut live electric cable on the floor there, and you go to try and help somebody who is, you know, falling on the floor, and you end up electrocuting yourself, definitely it's a problem. I remember there was a lad who was very good-natured. He jumped into the river in London, I think about 2 years ago, to try and save someone, and in so doing lost his life. So it's important to remember that you need to approach safely. And then, of course, you assess for the sign of life, where check whether this person is breathing. So you actually speak to the person, and if you don't hear any response, you probably shake them to see if they're responding. If they respond to you and they're breathing, but they're not opening their eyes and they're not, you know, engaging with you, then obviously you probably need to think about putting this person into the recovery position. But if they're not, and you don't feel a pulse, and you don't see them breathing, then obviously it's about time for you to start calling for help. In this country, it's not 911, it's 111 or 999, and commence your CPR, your cardiopulmonary resuscitation. Now, the hands, as you can see on this side, are laced, you know, interlaced one into the other, and on the bottom half of the bone in the middle, that bone, the breastbone, just the bottom half, and you start pressing up and down. Obviously, you're doing so, ensuring you are locking your arms so the elbows are straight rather than bent, because otherwise you won't be doing it effectively. And you do that with the aim of reaching up to 100 or even beyond that compressions, and you need to be digging deep into that chest wall for it to be at least 2 inches, which is like 5-6 centimeters. So it's not an easy thing. And within 2 minutes, you would definitely, if you're doing it correctly, you would be tiring. And therefore, you probably will need somebody to help. But if you haven't called for help and the ambulance crew is not on the way and there's nobody around, you could do as much as you can as a single individual, really. If, however, there are signs of life, like I said, you need to be thinking of putting them in the recovery position. But then we needed to look at some of the facts of heart attacks and cardiac arrests. Now, as you can see, the bystanders who might be there, if they actually do nothing at all, 5% of people who have gone into cardiac arrest would probably survive. That is, if they're very lucky. Other than that, most of them, as I say, up to 95%, 100% might just die. But if you do your CPR, you then treble the chances of survival of this patient or this person who's died. And as I say, as you can see, 1 in 10 people survive the sudden cardiac arrest. For those who have the defibrillators and the CPR, at least up to 5 of them can survive, you know. So it's a good thing to know how to do CPR. And if possible, if you have a defibrillator, then obviously it's important to use that as quickly as possible, because the ones we use nowadays are automated. You just press the button after you've applied the pads, and they will tell you what to do, because they will read the rhythm the patient or the casualty is in, and they'll tell you whether to shock or not to shock. And all you do is, if you are instructed to shock, you shock and look for a sign of life. If not, then obviously continue with your CPR. That's how it is. And in that way, you'll be helping that person to come back to life 3 times more than you would have if you hadn't done anything. Now, if you look at the stats, there's a few figures here. As I said, 80% of people who develop sudden cardiac arrest do so when they're at home. And you can see this startling figure here, 360,000 of those happen annually in the US. In Australia, obviously, a similar figure as well. But 4 of 4, you can see 10 there as a figure, which means if you leave this CPR for 10 minutes, the chances of you bringing this person back to life are almost nil. So every 1 minute you lose, you're losing about 10%. That's what that translates to. It just tells you that it's definitely important for you to be able to start CPR, even if you don't have a defibrillator. It's absolutely vital, because time is of the essence, So there are risk factors that we all need to be aware of. If you look in the right slide here, at the bottom here, you would see that out of every 10,000 adults that suffer out of hospital cardiac arrest, 10 or 10.3% or 10 people are Black people, are people, and 6.5 are the Hispanics, and 5.8 are our counterparts, the Caucasian counterparts. So it just tells you that we are more at risk for obvious reasons. I don't want to go into that, but I think we know why this is happening, really. So it's important to remember that if you apply CPR in time, you actually will be saving this person's life. There's no questions about that. So that brings me nicely to this. What is a cardiac arrest? Now, it is, as I said already, a life-threatening abnormal heart rhythm. Mostly, it is caused by VF, that's what we call it, ventricular fibrillation. So as you know, the heart would beat boop, 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 boop. That's what it normally wants, the first bit, the second bit. But in this particular situation, VF, it flutters, like if you've had a cold and you go, brr, 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 that kind of thing, that's what it does. So it fibrillates rather than beats 1, 2, 1, 2, 1, 2. So that happens when the electrical activity of the heart becomes so chaotic that the heart stops pumping. And instead, as I said, it quivers and it fibrillates. So the causes are, as I've said already, one of them is the VF, which is because of the irregular or a chaotic electricity of the heart. It could be caused by a heart attack. And that brings me nicely, because a lot of people think a heart attack is actually a cardiac arrest. No, they're two different things. One leads to the other, and it's very important to distinguish these two. So the heart attack is caused by a coronary heart disease. If you look at the heart, in the figure of it is like a pear, but the bottom is the other way round, so it's upside down. And around it, you will see the small blood vessels, which are called the coronary blood vessels. And these vessels, as we grow older, because of the cholesterol we produce and we actually eat from our food, our diet, they get furred. And so therefore, when the heart is functioning as a pump, it needs the supplements, it needs the nutrients. And if it doesn't get there, then obviously you begin to experience this pain, which is angina. And if that is not remedied or not addressed, then
Sorry to interrupt, but we can't see any screens. I'm sorry. There's no.
Right. You're not seeing anything?
Nothing at all.
Oh, God. Can you see it now?
No.
I can just see you. If you want to try and share the screen again.
Right.
Share your screen.
Come out of this and see. It's annoying this.
Thank you.
Right. Can you see it?
It's loading.
Can you see it?
Yes, thank you.
Yes, we can
Showing
see
now.
it now. Thank you.
Let me see if I can get that on this slide mode. Right. So where
That's
were we?
great. Thank
Right.
you.
Can you see it now?
Yes.
Yeah. So as I was saying, I normally do that. As I said, the icebreaker we went into already. As I say, when you see somebody collapse, what do? You approach safely. You assess for signs of life. Is the person breathing? You speak to them, you shake them, and you check for a pulse in the neck. If there's no pulse, then obviously you start CPR. If there is a pulse and they're breathing and they can't respond to you, then you probably put them in the recovery position and call for 999. If at all in the process of waiting this happens, then obviously you will need to commence CPR again. And we talked about the figures already, although you couldn't see them, but there you go. 1 in 10 people would survive if no CPR is commenced and no AEDs, i.e. the defibrillators, are used immediately. So, but if you do commence CPR within a minute or two of the person going into cardiac arrest, you would definitely, and with the use or the help of a defibrillator, you probably can increase that figure to 5 out of 10, which is 50%, which is a good thing to have. So as I say, 80% of people who go into cardiac arrest do so when they're at home. So if you get your elderly relatives who may have left you and gone upstairs to the loo, and then you heard a thud or you haven't seen them for some time, maybe check on them and see whether anything has happened to them. And if it has, then obviously you would need to do what you need to do, assessing them and take it from there, really. Right, we talked about these figures already. And I said we were describing or defining what a cardiac arrest is. I think we got onto the point where we talked about the main causes. So as I said, the heart attack is not the same as a cardiac arrest. I want people to understand that. It's just a cause or a risk factor to a cardiac arrest. Cardiomyopathy, some of which can be inherited, where the muscle of the heart is diseased, is another factor, another cause. And there are congenital defects of the heart that we're born with that sometimes we're not aware of, but as we grow older, they catch up with us. So they can cause a cardiac arrest, sudden cardiac arrest. It happens sometimes footballers or people who are extremely athletic, they would be there in the field or running or track or something, and then all of a sudden they just drop. That, if you find out, that person may have a congenital heart defect that wasn't picked up when they were younger, or maybe they compensated at the time and at that particular point they decompensated. Again, the valvular diseases of the heart, again, they're a major factor. And of course, we have what we call myocarditis, that's inflammation of the muscle of the heart. That can definitely give rise to a sudden cardiac arrest. Those of us who like DIY, sometimes a live cable, electrocution, I think I talked about that earlier, that can cause the heart to stop. You know, a drug overdose, which we know is getting higher and higher, more common and more rampant, especially in these pandemic days, is also a cause, because people go into respiratory arrest when they inject, and then if you don't then see them or notice them in time, they then go into cardiac arrest, and so they can die of that, really. Again, you know, the menace of society where there's stab wounds, there's gunshot wounds and things, people can bleed, you know, catastrophically, and of course they lose blood so quickly, so fast, that there's no chance, there's no time to actually recover, and therefore they die. So because the heart stops, it's nothing for the heart to beat on. Again, hypoxia, where there's low oxygen because of various diseases, you know, can be a major reason why the heart can stop, really. First, it goes into respiratory arrest, which is inability to breathe. And then if that doesn't get cleared or addressed, it leads to cardiac arrest. So I'm hoping this will play. It's a very good video. I've said quite a bit. I wanted to give you some respite, you know, but whether it'll play or not, I'm not sure. If it doesn't, we'll try it later. Right, didn't play. So anyway, CPR, we talked about, as we were talking, that there are changes because of the pandemic. I think I said that already. Important changes for everybody to remember. So as I said, we used to talk about the rescue breaths, you know, the breath of life in people and all that. Nowadays, you can't do that. So what you do have is, again, you approach safely and shake and shout for help. And obviously, don't forget to call 999. It's absolutely vital. If you don't call 999, nobody will know you need help, and therefore help will not arrive. It's as simple as that. And you will tire yourself out. And if anything, you'll be doing more harm to that person because you're tired and you're not performing effective CPR, which is the key to the survival of somebody who has died literally, you know. Don't put your face close to theirs, as I said, because we know COVID-19 is, you know, respiratory illness. And so if this person is actually breathing and they got COVID and you're not aware of that because it's not written on their face, then obviously you stand the risk of getting infected. So therefore, you're not supposed to be putting your face close to theirs. And of course, all you do then is to give the chest compressions, and that's why it's there. Do not give rescue breaths, please. As I say, you're aiming for 100 and above, and you're actually digging into that chest wall, 2 inches, maybe 5-6 centimeters. It's very tiring. You could definitely do that correctly with your arms locked. You would see that in 2 minutes, you probably would be tiring. And you can continue as best you can until the ambulance, which you would have called earlier, arrives. So after the ambulance comes, they'll take over. Remember to wash your hands thoroughly with warm water and soap. And of course, if you can, then use your sanitizers, hand sanitizers. Very important that. So this is just a demonstration of what it used to be like. But obviously we've taken that off now. That bit where you breathe into people, number 3 there, we can't do nowadays. And the 4th one there actually tells you that in adults, when you're doing the CPR, you're using both hands, as we showed earlier. They're interlaced one on top of the other. In the children, younger children, you use 1 or 2 hands. But in the infants, as Dr. Uzogi, Ngozi Ediesajo will tell you, she's a neonatologist, and so she will tell you that it's actually the 2-fingered technique that you use around the chest, really. And if you know that there's no sign of life, then obviously you probably would have to continue as best you can, really. Again, another video. Hopefully this one will play this time. It's not playing either. Never mind. Okay, so it's a good slide, this. Heart attack versus cardiac arrest. I think I mentioned this. It's important to know the difference, that a heart attack is not the same as a cardiac arrest. I can't stress this enough. A heart attack is a circulation problem, whereas a cardiac arrest is an electrical problem. A heart attack is a blockage or the narrowing of the artery that I've said, described. It's around the heart. It cuts off or reduces the blood supply to the heart, and therefore causes damage to due to the fact that there's lack of oxygen. Whereas with the cardiac arrest, it's an electricity issue, whereby the electricity malfunctions, and as a result, can cause problems with the functioning of the heart. The symptoms of a heart attack may occur hours or days prior to the attack itself. That's one thing to remember. You know, the symptoms you have are chest pain. Sometimes people feel tired, fatigued easily. Sometimes they can feel a bit of weakness, lethargy, and of course they can feel sick. This is definitely one thing they describe. They feel sick just before the attack happens, and they would have difficulties breathing. Whereas with the heart attack, with the cardiac arrest, they definitely happen just moments before. They might just collapse. And when they collapsed, they definitely lose consciousness. They wouldn't be engaging with you. They wouldn't be speaking with you or talking to you at all. They are unconscious and they don't remember it. And they may not be breathing at all, but even if they breathe, they might just be gasping. So don't be assured that once you see them doing that kind of breathing, you think they're breathing. No, they definitely are just struggling, and therefore you need to be getting this sorted out in terms of starting your CPR. There's no questions about that. And they wouldn't have a pulse. Oh, man. I need to go forward. I'm frozen here. It's annoying this. Right, let's see if we go forward.
Hi, Dr. Kamara, are you having a few? Oh, that's it. Thank you.
For some reason, all my videos are not playing today. I don't know why. They're really good videos.
There's a message here that you might need to come out of presentation mode and then just click the link for the video on the individual slide.
Is that what it is? Right. Okay. Well, when I do that, I don't know whether you see it or not. That's the trouble with it.
Well, we'll let you know if we don't see it.
All right. Okay. Right. No worries. Let's go forward. We'll probably play them at the very end if at all we can do that, because it confuses it. So anyway, there's three names there. You can see Glen Huddle. I think most people will know him. He used to be a footballer himself and actually managed England. And Erikson, of course, is a footballer, as we know. And Fabrice Mu, our very own, was also a footballer. And there's one thing that is a commonality. There's a commonality between these people. Now, as you can see, Glen Huddle also suffered a cardiac arrest. And if it wasn't for an engineer, I stress, an engineer that actually noticed that this guy is definitely not in a good way and started CPR, he would have been gone. There's no questions about that. He is now working with the government, having survived, a cardiac arrest, just having celebrated his 61st birthday. Him and Robbie Savage, as you can see there, were celebrating, and all of a sudden, right there on camera, he went down and banged his head. It actually fractured his skull, and of course arrested. And within a minute or so, this chap, who was an engineer, came to his rescue and started CPR, and that's how he survived. He's now working with the government, like I said, to add CPR to the curriculum in schools. You see, yeah. The next one is Erikson, which is the most recent one. He was actually in the Euro 2020 football match, just towards the very end of the first half. He suddenly just keeled over and boom, and collapsed. And of course, for 10 minutes, they worked on him, shocked him, and thankfully he's alive. He's now got an ICD, which is something we'll talk about later. And we're hoping he would probably return to some form of sports, but obviously he's thankful that there were some people there who could act quickly, and therefore he's alive today to tell the tale. Fabrice Mu, we all know about this. Again, he was at the football, in a football match on the pitch when he suddenly keeled over. I think he was playing for Bolton at the time against Tottenham, if I remember. And of course, we know he actually was literally dead for 78 minutes, and thankfully took him to, again, there was a cardiologist at the arena there, or the football pitch where they were playing, the stadium, and he came to the rescue, and for 78 minutes they worked on him. And of course, we know the story that he's got an ICD and he's now an ambassador for the sport. But that did not end his life. He continued, and he's now a broadcaster. He's a sports journalist, So it goes to show you what can be done when one door closes. As long as there's life, you can still continue, Oh, no. This was just a TikTok to emphasize what cardiac arrest is. So cardiac arrest, as it is, happens, as I say, all of a sudden without warning. if someone is in cardiac arrest, we've said already, they collapse suddenly, and therefore they would be unconscious, and therefore will be unresponsive. And as I said, they won't be breathing, or if they're breathing, they would just be gasping. And so don't be, lured into that false sense of security, say, yeah, they're breathing. No, you need to actually start jumping on that chest in order to get this blood circulating around the body. And of course, don't forget, before you start that, remember you need to call 999. Other than that, you'll be not helping yourself. So these good friends of ours, you could see here, this one is a defibrillator. That one is a one as well, very mobile one. This one is what we call a Lucas. If you look at it, the shape of it, it's got two parts, this part there, and that part there, and that part on top of that. That's the third part. However, you look at this thing, it's like a piston. So what it does is it goes up and down. Now, the person sometimes might come in cardiac arrest. And if, for example, they have like a blood clot as the cause of the cardiac arrest, and they've actually showed some signs of coming back to life, or maybe you get some pulse, but yet they're still not effective, you then need to, what we call thrombolize, try and dissolve the clot. And of course, if you then get a pulse back, and then they go back into cardiac arrest, then you definitely have to do CPR for like up to 90 minutes. Of course, it's very exhaustive, very, very tiring. You don't have the manpower, you don't have the strength. So therefore, this was actually created, this Lucas. So what it does is goes up and down the chest, and all you'll be doing is after every 2 minutes, you'll be checking to see whether this person has got a pulse, and if they've got a pulse, or the rhythm has changed and the rhythm is compatible with life together with the pulse, then maybe you can stop it. Many a time it's been effective, it's worked. But as I say, it helps you because you don't have the manpower, and for 60, 90 minutes, you can't just do that. So that's what that does. Again, this is a video that I hoped would have played. I don't know if it will play. I doubt that very much. I don't know what's happened to the videos today. But hopefully, never mind, technology. I think it's where I am. I'm at work as I speak, and I think the internet is suspect. That's why this is happening. I'm on call today. Sadly, this is what happens when you don't have your own personal yeah, apologies for this.
That's fine, Mohammed. I think if it doesn't work, we can just talk through. I was just saying before you joined that whilst we know that today was a talk about cardiac arrest and about cardiac issues, really, we did say that I felt, as usual, that people may have other questions. So I was going to ask people to put things in the chat that, you've got the benefit of having two health professionals, and the fact that you've got two health professionals there might be things that you want us to talk about. The second thing I wanted to mention was these weeks, these health weeks and health hours are here for the benefit of those of you that log on each week. And thank you so much for logging on each week. But what I'd like is to ask you, what's the sorts of things that you'd like us to talk about? As medics, we have a particular view of what we think you might want to know, but in actual fact, we're here for you. So if there are topics that we haven't covered, or there are topics that you'd like to know a bit more depth about, please put them in the chat box, and I will try and source a Black doctor who will talk to us about these things. So this is in addition to any questions you have about today's topic. I thought I'd just add that to the chat. And Mohammed, I'm sure you won't mind answering other questions, because Dr. Kamara is an A&E consultant. Oh, he's off actually. He's not here at the moment, but he's an A&E consultant, which means that he's got a real breadth of experience with all sorts of things that just walk through the door. And so he's well placed to answer questions that you may have on lots of different things. So if you put it in, I hope people from the CAHN team are capturing what people are saying so that we can look for specific specialists. Because as I say, this day's for you. It's a pity. This is the other thing, that you think that the NHS is really good with their Wi-Fi and really good with their technology, but it's not very good actually. It's not as good as it could be. And this is why Dr. Kamara, who's at work today, is experiencing these problems. So what I'm going to do is that we've got a hand up, but there's some questions that are coming in the chat. And I'm really pleased to see lots of your suggestions. That's great. And if you are watching us on YouTube or on Facebook, please contact our team, go to our webpage and put in your questions. Men, please put in your questions too. I'm seeing lots of questions from ladies about menopause and HRT and POS, but we'd like to get the engagement of our Black men as well. So if there are things you'd like us to talk about for yourself, please put it in the chat. And if you're a bit shy, just put it into just DM me. Just send me a direct message.
Someone's at your door.
Okay, so what I'm going to attempt to do before Dr. Kamara comes back is I'm going to look through the questions that are coming up. I think, as I said, I knew that there might be something about COVID, and there's a question here about the purpose of the COVID booster. As a rider, I'm a neonatologist. What a neonatologist is somebody who's a doctor who is a specialist in looking after premature babies and sick babies. But as a medic, I cannot have failed to have been involved with all the discussion about COVID, because what tends to happen is that relatives and friends approach me because I'm a doctor. So I've been used to trying to find the latest information and also trying to guide them about what to do with COVID. The booster is because we've found that your immunity after you've had the COVID vaccine wanes. And that's it. And unless you are immune, you may be affected by COVID. So the reason for the boosters, the short answer and the reason for the booster is to ensure that our immunity to this disease stays high. There's a subtext of that. I know that there's been a lot of discussions. I was on a national call yesterday about people's hesitance about the COVID vaccine and the booster as well. And also the fact that there are lots of people who feel quite, I don't think it's too strong a word to say aggrieved about being forced to take it now. And that's especially if you're a health worker, where you haven't been given any choice. I think there are lots of people who understand the reasons for the vaccine, but will still like to retain the choice to do that. So there's a hand raised from Faith. Faith, would you like to ask your question or make a comment?
Yeah, I just want to ask a question.
Thank you, Faith. You go ahead.
Okay, I want to ask about epilepsy. Does epilepsy lead to mental issue, affect the brain?
Oh, okay. That's an interesting question, Faith. And there are lots of different reasons for epilepsy. And for those of you that don't know, epilepsy is fits or seizures. It doesn't, what can affect the brain is if you don't have oxygen supplied to the brain. And sometimes if fits are left uncontrolled, so they're not treated properly, that you can have a prolonged fit, and prolonged fits sometimes can cause you to have those problems. But a fit itself does not cause brain damage. But I think the association with brain damage is that you may have brain damage, which can lead to fits. So there is an association between the two, because there are people who have problems with their brains, either the structure or they've had an infection, that will then lead to fits. So it's when we're in medical school, and there are also, when you are a trainee, there's a whole section of many textbooks. There are textbooks that are written just about the neurology of the brain and fits. So a single question and a simple answer probably will not be enough to answer your question directly, but the short answer to your question is, does epilepsy cause brain damage? It's usually the other way around. I don't know if that helps. Do you have somebody who has a brain problem and now has fits? Is that why you're asking the question? Hello, Faith, are you still here?
Yeah, I have someone in Africa. She's my daughter.
Okay.
She have epilepsy
Okay.
when he was 2 years old.
Okay.
Now the thing affects the brain, and he was have a mental issue.
Yeah. Well, when you have epilepsy when you're young, it's much more likely to have associated problems with brain damage, especially if the epilepsy is not treated, because when you have prolonged fits, it causes your blood oxygen level to go down. And if you lack oxygen to your brain, it can cause brain damage. And that's why it's really important to treat fits.
Okay.
Okay, thank you, Faith, for raising your question.
Sorry.
Yeah, go
Sorry,
on.
I still need to ask, is there anything they can do now, like treatment, as they have the issue, like mental issue now? Is there any treatment for she now? I don't know.
The treatment for fits, there's a wide range of different sorts of fits. And so there's some tablets and medications called anti-epilepsy. So what they do is they treat the fits. What they do not treat is the underlying problem. So it may be that for a young child who's developed fits, that there was an underlying issue with the brain. So it could have been from infection, it could have been something that happened during the birthing period. There are lots of things that will cause that. So if you treat the fits, you may not always treat what caused that, what led to those fits. Okay, I'm going to move on to, I'm not sure, is Bola your first name or is Ehige your first name? Bola, have you got a question?
Huh?
Have you got a question?
My son is disturbed. You said what?
You have a question, your hand is up.
Yes. Patient with anemia easily contact any disease?
Okay, thank you for your question. The reasons why we feel that it's important to treat anemia. So for those of you that don't know, and obviously Bola knows about this, anemia is when you have low blood levels, so low hemoglobin in your blood. And sometimes when it's very severe, you need a blood transfusion, but often what you need is just iron tablets. So your question was whether by having anemia, it causes you to have other diseases. Now, what anemia causes is it causes you to be quite weak. And if you're weak, you're probably not in the right place to fend off other illnesses. But anemia in itself does not lead to additional disease. It could cause your heart to work a bit quicker and faster and work harder. But anemia itself won't cause you, for example, to have an infection. It's a separate disease process. But it's good to treat anemia because if you have anemia, you'll probably be quite weak. It'll make you very tired, and might make you more susceptible to other diseases, but it doesn't cause disease in itself. So what it can do is put a stress on your heart, because what your heart is doing, your heart helps to pump blood around your body. And if your blood is not very thick and it needs to be a bit stronger, your heart will try and attempt to do a bit more work by pumping that blood round a bit quicker to try and supply all your tissues with the right amount of oxygen. So it does put extra strain on your heart if you're very anemic. Okay, I hear that Dr. Kamara is back on the call, so I'm going to hand over back to him.
Hi.
So what we did in your absence is that one of the things I've been really keen to do is to find out from people who tune in what they would like us to talk about. So they've been putting that in the chat and it's been very instructive. But I've been saying that we need a few more men to put what they would like as well, because most things are about pregnancy. What else have we got? Menopause, HRT, polycystic ovaries, infertility, miscarriages. There is hypothyroidism, which can affect men or women, but I will look for specialists to talk about most of these things for you. And I also said, Dr. Kamara, that as a doctor that works in accident emergency, that you're well versed in looking at a wide range of issues. And so that anybody who wanted us to talk about additional things today should put it in the chat. And so we've had a few things that have come through. So there's been questions about anemia. There's a question here about the difference between the third injection and a booster. So the third injection is actually the booster.
Yeah, there's no difference there.
Yeah, there's no difference between the two.
Yeah, you might want to add that there are people who've got immunocompromised, like the ones with myeloma, cancers and things like that. Those people would be subjected to a fourth injection. That's one thing worth knowing.
Yeah, that's
really.
exactly, because they said you need to have a third one, and that isn't the booster. So they said, the NHS said, have a third one, and then we would look at a booster. So there is a difference.
Yeah, definitely.
Is that for you? Is that specifically to you? They've told you that?
Yeah, there's got a letter saying people with an immune.
Yes, that's the only difference. But for most people, for the general population, and for the majority of people on this call, your third one would be your booster.
That's
but
right.
if you're immunocompromised, the one set of people who that doesn't apply to are people who are immunocompromised.
Yeah. And I mean, the thing about the boosters we need to remember is that when people contract COVID, and as I say, thankfully it's just 2 to 3% mortality, you find you get what we call innate immunity. And that innate immunity is what nobody knows how long it would last. It could be 6 months, it could be a month, it could be a year. But based on previous experience, it's hoped that it will be 6 months and therefore maybe even longer. Therefore, there is the need to top it up, just like you have with the annual flu or, flu jab, because the virus changes itself, as you know, it mutates. And as we know now, there's 16 types out there. So if you have one vaccine that covers maybe 10, 12, and then of course, the ability to protect yourself is not up to that level where it was 6 months ago, yet it's still raging. It's important to actually think about, taking the third one really. But you don't want to do it too early. And that's why they're strict about the 6 months interval. If you go to anywhere where they're offering it, and you want to have it done, they would actually ask you when you do have it and look at the certificate. And if it is not 6 months since you had it, they would not, offer it to you.
Okay, thank you.
Yeah, go on.
No, I thought you'd finished. You go ahead. Sorry.
It's important to remember that there are the ones they're offering nowadays are the booster ones are the Pfizer and the Moderna. Because of the site efficacy reasons. I think they said the Moderna and the Pfizer are more effective in terms of the variants that we're facing now, as opposed to the AstraZeneca.
Thank you. I know that COVID still has issues for some people, and I'm so pleased that you're putting these questions to us about the various things that the concerns you have. So what I'm going to do, I first of all want to apologise about the issues today. It's the NHS, it's not us. The fact that NHS has such poor Wi-Fi that some of us tend to work from home when we're not looking after patients because you get better Wi-Fi in your own homes. But that's the constraints we have as medics working in the NHS. But thank you for persevering with us. I hope you found today helpful. I think what I found most helpful is looking at the list of things that you'd like us to talk about. I really hope that the Caribbean African Health team in the background have collected all that, because we are going to make sure that we find people to talk about this. In keeping with our November Health Hour, we are going to be looking next week at stroke and vascular dementia. So we've talked about old age dementia, but this is dementia that can come about from vascular issues, and it's going to be given by a colleague called Dr. Deji Olojuba. So thank you so much for joining us, and thank you, Dr. Kamara, for taking time out of your busy on call. You are a stalwart. You've come quite a number of times, so thank you for continuing to support our Health Hour. So we will see you all next week. CAHN team, have you got any last words to say?
Hi, Dr. Ngozi, thank you so much for that. And thank you so much, Dr. Kamara, for today's presentation. Yes, we just want to quickly plug in for our CAHN Healthy Hearts. For those that don't already know, we're doing our tailored support sessions. That's every Tuesday from 5:30 till 7:30 here on Zoom, which is also, we're doing our 24-week challenge, where we're encouraging people to look at our diets, look at our healthy eating, trying to see how we can make sure we're maintaining a healthy lifestyle together. So if you're interested and would love to join that, where I believe next week will be week 7. So if you're really interested and would love to be a part of that, just feel free to email us at events@cahn.org.uk, and we would love to have you on board. We're also still doing our physical activity session, which is also included on our Healthy Hearts. That's every Tuesday evening as well, so feel free to join those sessions. We also have our suicide awareness training, which will be taking place next week. And from this training, we'll also be offering some certificates as well. So if you'd love to be a part of that, that is next week, Friday, I believe the 26th of November. Yes, and we will also be promoting that on our various platforms as well. Yesterday evening, we also had our finance literacy workshop, which is a really good success, and to encourage everyone as well in terms of managing our finances. And that resource is still available on our Facebook and our YouTube channel. So you can always go back and watch that and, learn more. I believe yesterday we spoke about investment, property management. So you can always go back to our YouTube and our Facebook channel to watch that and encourage, friends and family in terms of how to manage your finances. So those are some of the events that we've had going on in the background. Yeah, thank you so much for everyone tuning in this morning. I know it's been a busy morning, but we hope everyone has a lovely remainder of the weekend. Yeah, over to you, Dr. Ngozi.
CAHN Health Hour. Giving Black health advice. Get informed today to have a better, healthy tomorrow.